Well, I want to welcome everybody to our Workforce Crisis Task Force meeting. As you know, this is a public meeting, so it is being recorded. We request that you turn on your camera to the extent possible to improve engagement and use our mute buttons to be respectful. We will be monitoring the chat box, so feel free to put comments or links in there as well. All of our presenters appreciate verbal cues to help us see if people are nodding along or if they're puzzled and need more information. If you need the closed captioning service, if you go to the 3 dots in your toolbar and click on that, you can turn on live captions. We will be doing some shared screen to show documents, but we'll try to be judicious about that so everyone can see each other while we're talking. And as a public meeting, we welcome all guests, but our guests do not participate in the meeting unless there's some specific point of information that we ask them to respectfully contribute. So I'm going to go ahead and start with the roll call per usual. So this is in alphabetical order. Jason Abadili. Says hi. Vic Gable.
He says he can't unmute himself. So.
Oh, you were having that problem earlier. Yeah, we knew he was here. Okay. Kim Howe. Yes. Kristen Henry. I don't know if I saw.
Good afternoon.
Hi, Kristen. Deborah Hoffine.
Hi, everyone.
Debbie Jenkins.
I'm here.
Willie Jones.
Good afternoon.
Kim Kelly.
Hi, everyone.
Teresa Cobell.
Here, thanks.
Pete Moore let me know that he had an unavoidable conflict and wouldn't be here today. I think Scott is here if we need to ask any questions or garner any input. Rivo Mirnix.
Here, thank you.
Janet Stefan.
Hi, everyone.
Bethany Toledo also let me know that she wasn't going to be able to make it today, so we will keep her in the loop about what we do today. Gary Tonks.
Hi, everyone.
Nate Turner.
I'm present. Can you? Am I unmuted? Oh, okay, I'm present.
Nope, we can hear you.
Okay, great.
Jason Umstadt.
Here.
Renee Wood.
Here.
Hi. All right. So with attendance taken, I will turn
Jackie,
the agenda over.
Vic, can you try again?
Yes.
Thank you.
Hey.
Thank you.
Good afternoon, everyone.
Sorry, Jackie.
No, I'm glad we got that to work. All right. So we're going to start today's agenda with a welcome from the director. We then have a couple of reports and updates on projects that have been in progress around crisis staffing support, some of the Medicaid developments we talked briefly about last time, some direct support professional RFP that you want to talk about. I think we also have an update on the shared living, marketing, and communication pieces, and then time permitting, anyone else with additional proposal that they want to put in the mix, we'll have time for that to happen as well. So let me turn the agenda over to Kim.
Thanks, Jackie, and thanks everyone for being here this afternoon. I wanted first give a shout out to all of you for your patience while we got the provider relief payments in place. Hopefully you've all received those. There's only, I think, as of this morning, about 60 payments left to be made from the department. I also want to thank the Medicaid division here at DODD and the fiscal division for all of their hard work in ensuring those payments got out quickly. So I wanted to start with that. And you're welcome. Thanks, Michelle. And then just, I'm excited to hear your thoughts and input around the DSP RFP that we talked a little bit before, and just anything new that's going on. So I don't want to take up a lot of time. We'll get going.
I think you're muted, Jackie.
I said the incredibly important thing that you were next. That's all I said. So you are next. Thank you for pointing that out, though.
Yeah. Good afternoon, everyone. I just wanted to give a brief update, and I'm going to also, I think it's important to provide the what and the why, so I'm going to run a short video as well. But building upon DODD's Regional Residential Crisis Support Plan, which we have in place and which I'll, at the end of the presentation, show you where it's at on the website. I will run a video from Director McElroy to talk about the residential RA3P program that they have in place. So the DODD regional contacts that we currently have in place, one of the challenges has been engaging with them to the next step when it gets into staffing crisis that maybe can't be addressed locally. So Director Hauk engaged with Director McElroy several weeks ago, and to find out how can we as a system leverage without duplicating efforts, but instead supporting efforts for the DODD system, their existing what they call the R3AP program. And specifically that is Regional Residential Assistance Program, Response Program, Rapid Response Program, which is 24/7 coverage. So one of the modules of their rapid response for the nursing facilities is staff crisis management. So that's going to be what we're going to feature going forward. So I'm going to attempt to run the video. So bear with me for a second. We got some new features and teams. And just let me know if you all can hear the sound. Is that good? Thank you.
Hello, I'm Ursel McElroy, Director of the Ohio Department of Aging. Thank you for your interest in our new Crisis Staffing Assistance Initiative. Since the emergence of new variants of SARS-CoV-2 and the continued rise in COVID-19 cases, staffing shortages have reached a critical level in Ohio's long-term care facilities. Staffing shortages can pose considerable risks and compromise the ability to consistently and safely meet the basic care needs of the residents, appropriately monitor residents with complex medical needs, and properly staff COVID-19 units and prevent premature transfer of residents to hospitals. It can also limit your ability to administer timely monoclonal antibody treatments, comply with infection prevention and control practices, accept new residents and properly onboard new staff, and facilitate visitation between residents and their families and friends safely. The Ohio Department of Health, in partnership with the Ohio Department of Aging, is committed to providing services to long-term care facilities during their response to SARS-CoV-2 infections. Recently, the departments have collaborated with the Ohio Board of Nursing to solicit support from retired or otherwise unemployed nurses in good standing. Together, we have developed reader-friendly documents to complement the CDC guidance on conventional, contingency, and crisis staffing standards. We've also enlisted on-site assistance from the Ohio National Guard during extreme staffing shortages attributed to a COVID-19 outbreak within a facility. Now we offer crisis staffing assistance. And although I encourage you to first explore the resources that exist within your organization and your community, This may include availing yourself of available nurses in your neighborhoods, engaging staffing agencies, refining recruitment strategies, restructuring the resources within your organization, such as involving leadership staff in essential functions, and applying the CDC crisis staffing guidance when you can do so safely. However, I know that sometimes you can exhaust all these options and still not acquire the timely help you need to ensure the safety and well-being of your residents and staff. So we have forged formal partnerships with entities experienced in providing healthcare crisis staffing, namely registered nurses, licensed practical nurses, and state-tested nursing assistants, to offer staffing help to you when all other reasonable good faith efforts have failed. Our resources are limited, but we are here to help when no one else can. Our goal is to provide crisis staffing assistance when no other options remain. The assistance is available on a short-term basis, and we understand that each situation is unique, and we stand ready with the will and the expertise to explore your options and help you get the assistance you need. This assistance is available through Ohio's Regional Rapid Response Assistance Program, or what we refer to as RAP. With leadership and support from Governor Mike DeWine and members of Ohio's General Assembly, RAP makes available strike teams to help Ohio's long-term care facilities address critical issues related to the COVID-19 pandemic. The RAP model effectively connects public health with long-term care facilities. RAP is a trained and equipped multidisciplinary team that provides around-the-clock support with expert clinicians available to facilities in times of outbreak, as well as the ability to provide consultation on best practices and supports. RAP teams are designed to deploy rapidly and efficiently to facilities to help with disease protection and response, limit transmission, and lessen morbidity and mortality.
So I just wanted that kind of, there are other, she goes into talking about some of the other modules that they have for PPE, but we already have that structure in place within DODD. So within the past few weeks, the DODD team has been working with aging to update. They've got a web tool that corresponds, and they also have a call center to facilitate any emergency staffing crisis requests for ICFs. And as Director McElroy had stated, the staffing resources for these emergencies is really short term, 2 to 5 days. In other words, it's not intended to provide long-term staffing solutions for the intermediate care facilities, but intended to really target when there's an outbreak, or in the case of what we're experiencing now, staff shortages. So Ann Weiss and her team, and we are in the process of developing an around-the-clock support on call for this. I can tell you the system, the tool's been up and running probably since the end of January, and they haven't had that many that reached a critical point, but having this in place, I think, for our system is very important in the event, we don't know if there will be another variant in the future and things like that. And we know that there are some facilities who may need that immediate emergency response. So again, Department of Aging has been gracious. So the work that's been going on is really customizing. There's a series of questions and resources. I know that Ann Weiss from our team has been working with the County Board Association to include who the local contacts are. So the point is we still want to go through our regional crisis support plan process. This is just that one last emergency step. And for those of you who may not be aware of that information or that resource, it is on our website. And basically it talks about how engaging with county boards, local providers at the local level, and it's really to address this step 4, where it gets into a strength team and help for final resolution if local resources aren't available. So hopefully that makes sense to where we're at with this, and we'll be testing the new web tool next week. And if all goes well, we'll have this up and running in the coming weeks.
Any questions for Rival or any thoughts?
We just really appreciate the department reaching out to aging and getting this set up. We hope that it'll be something that providers will be able to utilize and help them, even if it's just in the short term. So thank you, Riva, and thank you, Director, for reaching out and getting that set up through the Department of Aging. Appreciate it.
Of course, thank you.
Okay. All right, thank you, Rivo. Next, Deborah Hoffbein's going to provide us some RFP or some updates on some of the Medicaid developments. Deborah?
Good afternoon. There was just a couple things that I wanted to touch base on. We are still working on the RFP that we will be publishing soon, we hope, by the end of this month, regarding the modernization of our reimbursement system. So that's all the work related to that third prong of single assessment, single plan. It's the single budget part. Hopefully we can get to a place where our AAI and DDP are appropriate budget assignments. And of course, we're going to be looking at our rates on all of our services, as well as some of the service definitions themselves, our shared living and some other services that, you know, we have heard feedback from the field that are not necessarily always meeting folks' needs in the way that they might have been intended. So we are still working on that. We had shared a draft of that RFP with our with NASDs, the National Association of Directors of Developmental Disabilities Systems is what I think NASD stands for. And it's a long one. And they were able to provide us with some really, really, really valuable feedback. And so we're taking the time to incorporate some of that to really, really get the RFP to be much more clear and expressive about what it is we're after. So while that did delay us a little bit, us getting it done, the feedback was just exactly what we needed. So it's definitely time well spent. So more to come on that. And then the other thing I had said I would touch base on is the Medicaid Enterprise Portal, the part of the OMS, Ohio Medicaid Enterprise System, work that's being done for the July 1st release. Part of this is connected to Nate's proposal we talked about a while back with possibly providers not having to be certified separately for different agencies that provide very similar services. And if that could be streamlined somewhat, that might help our provider workforce issue. And so what I wanted to say toward that end is that the Ohio Medicaid Enterprise System will help, but it won't quite get us all the way there. The Enterprise Portal is to be the single point of entry to all activities Medicaid in Ohio. So any provider who is participating in Medicaid programs of any kind, so our waivers, passport waivers, assisted living, and even doctors and hospitals will use this portal to access their Medicaid information, submit their Medicaid claim. Well, our providers won't submit their claims there. They'll still submit to us. But it's the single point of entry for all activity related to Medicaid. And it will be the single point of entry for all Medicaid certification activities. So, I think it lays a good groundwork for us to start to move in the direction that Nate was describing. It doesn't get us all the way there because it doesn't touch the certification requirements that each program has, but it will start to put providers going through a single front door and having a single Medicaid provider account. And so I think once that is up and live, we could start to do a deeper dive into those conversations around where our requirements differ from other waiver programs, where they're the same, and where we could possibly work with the other agencies to align. So I think it's an incremental process, if that helps at all. But I do think it creates a good foundation for us to start to move in that direction. So, Nate, you have a question?
Thank you for giving the update on that. I do really appreciate it. I think it is certainly an effort in the right direction. I would say that it would be very important to make sure that there's plenty of just tutorials on how to navigate the process, because you hear from or at least I've heard from a lot of direct care workers that when they have to apply using the same forms that a doctor or a hospital would use, it could be daunting and confusing for them. So anything you all could do when creating that single point of entry to have tutorials that go along with it, I think will ease some of that consternation and hopefully remove a barrier from people even filling out the application.
I think that that's definitely part of the rollout plan. I know at least for particularly DD providers, we will be very aggressive in the training and the education and the resources that we make available. So if I can kind of describe it in a very simplistic way, that the Medicaid Enterprise Portal will create a single point of entry, and providers will be asked a series of questions. And and one of the questions is what do you want to do related to Medicaid? And if they want to be a DD waiver provider, there will be a way, an interface that will send them to us. And so it's still going to be our provider services management system and the same forms and the same requirements we have. And if they say, I want to be a passport waiver provider, their information and their application, to the extent that it's completed, will then go to aging, and aging will have whatever their other requirements are. And then it'll come back to that single point of entry again, to that provider's single Medicaid account. So, which is why I said it's a step in getting us closer, because providers will all have a single account to work from. And then I think that lays a good foundation for the sister agencies to work together to talk about, well, what are we asking providers for that's different than what aging is asking for, and is different what home care is asking for, so that we could possibly get to that one place. We had attempted initiative like this maybe about 10 years ago, and it didn't get very far, primarily because every agency had its own portal, so to speak. Each provider had to go to each place, and those systems didn't talk to one another at all. So now that we have I hope this works in July the way it's advertised, the way they're telling me it will. Like I said, that's why I said I think it makes a good groundwork. We've overcome that hurdle of systems that don't talk to each other now. They have to talk to each other. Every Medicaid provider will have their Medicaid provider account in one place, and the different systems will feed into it. And so I think that takes a big barrier out of the way to get to where you want to go, which is then the requirements can be better aligned. That's my updates. Thank you all.
Any other questions or thoughts before we keep going? Okay, thank you, Deborah. Steve, you're next to give us an update.
Yeah, thanks, Jackie. I think most folks, not all, but most folks were on a call a few weeks ago where we introduced the idea of this direct support professional RFP. We got a little bit of feedback on that and have since kind of circulated some ideas amongst some of you and had some conversations. And so I just wanted to kind of check back in with folks. We provided, I know Jackie sent out kind of a high level summary of what the RFP is intended to accomplish. And so hoping you had the opportunity to take a look at that. And I can provide just a quick overview of it. Essentially, we are really trying to get at supporting DSPs and their job and different ways to do that. Finding new creative ways, maybe ways that have been tried but maybe not scaled, and really looking for creative ideas around supporting DSPs both in their job and how to find more to come work in this field. So there's 5 different kind of areas that we proposed that people send us proposals to work through, and then one of the outcomes of it would be for grantees to be able to provide us with some data at the end of their project to let us know how it worked, if it worked, and then what can be done to either scale it or do better amongst more and more providers across the state and DSPs. So I really just wanted to have an open discussion or suggestions around it. We are definitely open to hearing.
So this is Kim Kelly. Today I was in one of the frontline meeting, and Nick Miller was there and Corey Ferguson. And one of the things that this was with a group of DSPs and some agencies and other organizations. And one of the things that came to mind when I was listening to what everybody was having to say is that when we talk about home care, it is such an ambiguous situation for any given family because of the family dynamics, because of the difference, the diversity and the disability that's being served, and everything, all the other factors that come into play. And in all the years that I've been doing home care, 2 things have been sorely lacking. One is training the family how to accept these strangers into their home and how to develop a home care model that is conducive to the outcome that's in the ISP for the individual that's being served. And on the flip side, we don't really offer any training to the DSP before they walk through the door to know how to engage with the family and to work with them on a team level with the consumer that they're going to be serving. And I don't think that it needs to be very detail oriented. I think there can be some very high level training that can be offered to these 2 groups of people that will help them to understand the scope of the job. I mean, I've had DSPs come in, for an interview, and I've taken them through the house. I've showed them all the equipment. I've told them exactly what has to be done. They're like, yeah. They get hired in, they walk through the door, and you start hands-on training them, and they kind of look at you like a deer in headlights, and it's like, I didn't sign up for this. And not only do they walk out of the house and never come back, but they leave the field. So I think I think by having some formal what to expect training not only for the family members who are trying to develop home care models, but for the DSPs that are serving them, will just set expectations so that people do not, so they're not unrealistic about what to expect. I think that's part of the issue with finding, or not for finding, but for hiring and retaining people long term.
Thanks, Kim. Nate, I see you have your hand up.
I just want to agree with everything that Kim said and also say that I think it's imperative that people with disabilities, maybe hopefully whoever the grantee is, will be inspired to involve people with disabilities in such a training that Kim mentioned, because I think it's pivotal that it represents our voice.
Thanks, Nate.
This is Teresa, and Nathan and Kim. I was just sitting here thinking, Steve, whether it can be a part of that grant, or I don't think DD Council is on this group, but I thought it might be interesting to see about like mini grants to people with disabilities or families to make their own kind of video about what a day in the life with me is like, as part of finding providers, matching, however you want to think about that. But so whether that grantee could almost make a template or something that families could, or people with disabilities could put information in, or again, if Carolyn were here, she's always offering funds for something. This might be an interesting kind of DD Council mini grants to families kind of a thing.
So I just wanted to add to that Nick Miller and Bethany Toledo and I are going to try to get together. Bethany wasn't in the meeting today, but Nick's going to contact her, get together and see if we can't brainstorm and try to come up with something like that, possibly, Teresa, where, where families can do like a short day in the life, or, I mean, that to me is really huge, but just even if we can do some generic stuff, because from the standpoint of a self-advocate who can self-direct and the standpoint of a family member who has to direct, I mean, we're miles apart. And then when you talk facility-based, that's even further out. And so I'm not trying to make this complicated. I'm hoping that we can simplify it to where it's just hey, this is kind of the scope of it from different perspectives, and put that out there, kind of like a public service announcement. I don't know, but if anybody's interested in being a part of that, certainly, put your email in the chat and I'll write it down. And when Nick starts to bring this together, I will let him know that you're interested in participating in a group that formulates some of this.
This is Gary, and I couldn't agree with you more, Kim, especially in our videos tend to be warm, cuddly people that walk and talk. And I do some training for, they tend to be jocks at OSU who think an entry special ed course is an easy A. And I do a presentation on you potentially are going to get peed on, pooped on, smacked, and it's all still worth it. And you really need to know what you're getting into. And it's a wonderful, I mean, I've been doing it for over 40 years. It is wonderful, but you need to know the hazards going in, especially if you're making $12 an hour. And you need to know at the end that it's worth it. So I love the generic. There has to be something generic, but there's something very different between escorting someone to a movie theater and changing an adult. It's very, very different. It takes a different skill set. I still can't lift because I still have back problems because no one, when I was 20, told me how to lift a guy and transfer. No one taught me those practical skills, and no one told me I would have to change a woman's pad during her cycle because there was no one else to do that. I mean, and I grew up with all brothers. No one told me that, and it wasn't appropriate that I had to do it but I had to do it. You know,
And I think the other important thing that DSPs need to understand is that in many situations, they are going to have to learn how to self-gratify from their experience, because there's nobody is going to be there to pat them on the back and say, hey, good job. And I sincerely hope that we bring people who can self-gratify into the field, because it would be awful lonely if they didn't.
and there's no one to call.
Right.
You're there by yourself.
Right.
With 4 to 8 to sometimes 10 people, and you're there by yourself. Then there's no one to call, especially when the electricity goes out, and it will go out. You know.
Yeah. Yep. Been there, done that.
So any other thoughts or input into the RFP process? And then there is a question in the chat room about background checks, but I wanted to make sure that there wasn't any more feedback or thoughts around the RFP before we turn to that.
Steve, is it still $100,000?
That's currently what we're looking at. Yeah. And
Okay.
we haven't completely vetted this all the way. But the thought is we may have to split some of it up if some of it turns into training type proposals versus grants and ideas. And so there might be a little bit of nuance in there that we might have to split it up, but that's still the idea of the total pot.
Okay.
This is Kim again. I just want to respond to Janet's question in the chat. No, the answer to that is I don't assume anything. When I interview people for the job in my home, I go into every level of detail of what they're going to be doing, right down to, putting him on the toilet. And then I take them through the house and I show them the durable medical equipment. I show them where, all the supplies are. And, because we have 3 rooms that are specifically dedicated just to the care and treatment of my son. And they are all absolutely fully aware of what the scope of the job is before they ever walk through the door and start. And still, day 1 to a week, I've had people just turn around and walk out because it's not what they signed up for. It's one thing to talk about it, and it's another thing to try and do it hands-on. And I think that most people that come into this field do so with not solid expectations about what the job is going to be, but they have the heart for it. And you kind of, when you're dealing with somebody with complex needs or medical fragility, you have to have a heart for it. And it doesn't matter whether you're doing it in the home or in a facility-based program or placement. It does take a special type of person, but you can take a person who's not that special and you can teach them what they need to know, which then allows them to grow into that role as a direct support provider.
And Janet, I share your comment. I mean, here. There are thousands, and most of the agencies. I would love to see some data from maybe Opera and the Healthcare Association of how many bodies, individuals are served by agencies that we recognize as trade associations. But it's more than half don't belong to a trade association and aren't getting the training that you all are giving your staff.
Gary, I got to plead ignorance because I was not part of the meeting and I haven't seen the RFP, but I'm just surmising from the conversation that there's some thought that maybe enhancing training in some way might help with retention. So that's why I asked the question. If we were basing on the assumption that we don't try to prepare staff in either the interview process and or during the orientation process about the scope and diversity of the job.
Right.
That's
my point is I know you do, I just also know that there are a lot of agencies that don't, and I don't think those agencies are here.
No.
And there's a lot of IPs that need it as well.
Right.
Vic has been waiting patiently to jump in.
Thank you, Jackie. Steve, thanks so much for sending out this summary of the RFP. Just something that strikes me when I was reading through this yesterday was, and I see this in my work as a CARF surveyor when I travel around the country. There's a lot of people, much like Ohio, they're struggling with the maintaining and keeping DSPs. And it may be somewhere embedded in this RFP, but it's not jumping out at me, is that there be some notion of during the scope of work that there be places and some expectations that the RFP group would work with the agencies, both large and small, to make sure that there's infrastructure, as far as workforce development, because all these training things about inspiring confidence and recruiting and retaining, you need a structure within that particular company to have that. And, so it would make sense to me as a former CEO, that you look at how your company is set up, so that if you get all these trainings, how do you maintain that ongoing? So this is an ongoing piece, and maybe it's already in there, Steve. I don't know, but I would think you would want to include that in the scope of work, that there be some business model review, for lack of a better term, as you're going forward with it. So that's my 2 cents with it.
Great, thanks, Vic.
Any other input on the RFP? Okay, if not, we do have a question in the chat room around background checks. Kim asked, why is it taking so long, and is there anything DODD or ODM can do to ensure there's a timely turnaround once submitted? So I don't know if that's in your bailiwick, Deborah, or someone else's.
Well, I assume it's me as much as anyone. We try as much as we can to work very closely with the BCI folks to turn around background checks as quickly as possible. But we really don't have any real control or influence on how they do their work. So what we do try to do is, even through the pandemic, when the department has been fundamentally remote, I send staff in every day to check to see if we received background checks, because we do get them on paper, and to get those scanned in and posted to the provider's application, so that the application can continue through the process. As like I said, so the things that we can control, we do. Once we get a background check, we don't, it's not sitting in a bin somewhere. We're checking for those every day, posting those every day, and dealing with them. If it's been more than 30 days and someone reaches out to us, we can reach out to the BCI folks to request that they give us a status. Sometimes they will, sometimes they don't. Again, it's just an entity we don't really yield a lot of influence over.
So I think the reason Lauren asked the question, Debbie, was she wanted to know if there was something that DOT or ODM could do in working with the BCI people to when a claim comes across for an independent provider or an agency provider, to expedite that specific thing, like if they get moved to the front of the pile. And I mean, I know it's a different aspect of the government, but is there any way during this crisis, at least, you know, kind of like we have Appendix K, can we have something that we put in place at, you know, with that government agency that will allow them to expedite those applications?
I can certainly, work with our legal team. Most of this is all handled in the legal division.
Right.
We have attempted this before. They have not been particularly responsive. I think, sort of in their eyes, everyone who's asking for a background check needs it for a reason. And
right.
Our reasons are not necessarily any more important than others, whether that's, of course, wouldn't be my take, but again, people just don't get background checks to know if they're a felon or not. They're doing it for a reason. And so BCI is, and it may just be how they manage their workload, but they are very much first come, first serve. I know Jeremiah is here. That could be something that our communication and our liaison through the administration could maybe initiate some conversations. I just know as me and our conversations we've had with the BCI folks, if we have an extreme emergency, we can sometimes get something expedited through them, but just qualifying for our expedited independent review process would not rise to their level of emergent. So,
Is there someone that that this particular advocacy group could contact to just even have an open discussion about the issues that they are experiencing?
Again, I think before any of that happens, I think it makes sense for our legislative liaisons to discuss it at the governor's office, at the administrative level, to see where might be the best way to effectuate something like that. Because we don't want to alienate them.
Right. Well, that's why I'm asking this group, because it all ties in with the workforce. I mean, the ability to get somebody through the door, you have to have that background check, and we understand that. But there's reports of people waiting, so long that their application actually expires.
So if there are examples like that, I'll find out if we know of examples like that, and I will make the commitment to talk to the administration about it, and we'll report back.
So some of the
move on.
Sorry, Kim, but some of the sorry, Director, I got to get used to saying that.
That's okay, Gary.
So some of the concerns I get are that it's not BCI. It's our potential independents don't know the proper code to give the generic person that's actually doing the prints. So it's not a BCI, it's not at an agency level, it's that place around the corner that takes my prints who doesn't know the proper code.
Right.
And even if they get the print, they send in the wrong code, which gets sent back. And this, for me, is primarily the independents. They don't know that they gave the wrong code to someone. So we're not, and I just asked David, who does it for us, he said, we're getting ours fine. And they're coming into and we do it for a lot of families, but we tell mom, go get your print, and this is the code you use. So it might be as simple as that, but I have no idea how to talk to the people actually doing the fingerprints. But we're not saying that it's BCI. It's on a local level.
And
thanks, Gary. That's what we've heard, I think, as well.
And in our application training materials, I guess, if you want to call it that, there's information on our website that's very specific to all of that. But if an applicant isn't going to look at our website to know the proper steps, we don't know an applicant's an applicant till they're an applicant. So we have a hard time getting maybe the information into the right hands, but it is readily available on our website to exactly how to request your BCI and what address where you put where it goes. There's very explicit instructions available. So hopefully that helps.
I think it
But
will.
again,
Yeah.
like I said,
It will. We tell our families the certification process is an interview test. And some of you will not be able to get through the interview. I'm pretty blunt with our families as well.
All right, I'm going to turn the corner on this because one of the other things that the department has followed up on with help from all of you is on some of the materials around Ohio shared living. So Steve, I don't know if you wanted to show those to folks real fast or at least give people an update.
Well, I can see if I can pull something up here pretty quickly. I know Jeremiah's been coordinating. Okay, go ahead.
Sorry. Yeah, I am not prepared to share those today, but I can provide an update. So a subgroup had formed around the concept of Ohio shared living and wanting to get out some promotional materials around the service. So we've the communications team at the department has revised some communications that we already previously had that I don't think are kind of widespread known or out there. So we do have a website. We do have a video series that the communications had done a number of years ago, as well as a 2-pager. So we try to take a look at those, again, at sort of the advisement of the subgroup to make them more easier to understand, easier language, and more relevant language. So a little lighter on the OAC and a little heavier on the practicality of, I think, some of the things that we've talked about here today. So the subgroup does have those materials, and we are meeting next week to look those over as a group and see if there's revisions to be made, and then if there are some next steps or some gaps that we've missed. But that's where we stand.
Okay, thank you for that. I also wanted to give us, I know we have just a few minutes left. I know one member has turned into me a proposal that we will look at next time. They're still fine tuning it a little bit, but they've got a proposal in the work. I know that a few of our other proposals that we talked about last time are also sort of in an action step mode right now. So I anticipate at the next meeting, we'll have a few of those updates and perhaps a new proposal to consider. I wondered if anyone else had any other ideas, whether they were ready to be a proposal or just any other idea that you wanted to have an opportunity to share today so that, work began. Okay, not hearing any. I will just reiterate that if you do come up with anything, forward it my way. If you're struggling to figure out how to put your idea into a proposal, Steve and I are happy to work with anyone to help flesh it out so that you feel, comfortable proposing to the rest of the team. And as I said, I do know there's at least one in the pipeline for next time. So that covers what we wanted to make sure was covered today. Anything else anyone else wanted to bring up or do an inquiry on before I hand it back to the director for final thoughts? Director, back to you then.
Thanks, Jackie. Thanks, everyone, for the good conversation. And it sounds like we will be getting a DSP RFP out soon. And hopefully we'll get lots of great ideas and applications. So you all take care and have a great rest of your week.
Thanks, everybody. It was good to see you.
Take care.
Thank you.